Welcome back everyone. Today we will discuss about a case of a 66 year old man. So this patient presented with a whitish patch over tonsil and along with anterior pillar. So tonsil and anterior pillar. In this biopsy, they have taken the biopsy from anterior pillar of tonsil along with surface of tonsil. So we can appreciate this mucosal lining here. This mucosa is comprising of stratified squamous epithelium. So there is acanthosis, means this stratified squamous epithelium that is proliferating, and the thickness of the stratified squamous epithelium is increased. From a low power view, we can appreciate this coilocytic change. Coilocytic change means these perinuclear clearing along with enlargement of the nucleus. So both the features are here. We can appreciate prominent nucleoli here also. There is prominent nucleoli with this perinuclear clearing and nuclear enlargement. These features all together called as coilocytic change. So coilocytic change is there, and these parakeratosis is also we can appreciate. So parakeratosis means nucleus and nucleated cells at the very apex of the layers of stratified squamous epithelium. So at the very apex, here it should not be, nucleus should not be present, but here we can see that the nucleus are present at the very apex of the stratified squamous epithelium. So there is this parakeratosis is there, along with hyperkeratosis is there, acanthosis is there. Now we can appreciate here there is at least mild dysplasia, or we can appreciate that the dysplasia is minimum at the lower 1/3 of the stratified squamous epithelium of the mucosa. So there is marked nuclear, and we can appreciate multiple nucleoli here. Along with we can see these intracellular bridging is prominent here, and nuclear anisonucleosis. There is a variation in the size and shape of the nucleus with nuclear enlargement. Nuclear size is increased along with a few mitotic activity that is there. So in the subepithelium we can see these tumor cells. So tumor cells are mostly arranged in nests, lobules. So we can see these nests and lobules, and we can see these keratin pearls. This is keratin pearls. So there is maturation is there, means they are differentiating. So these are beautiful keratin pearls, which are nothing but the eosinophilic cytoplasmic remnants of the these epithelial cells. So this is one nest or lobules. In this there is one big keratin pearls, acellular keratin pearls. So there are few keratin pearls are there, and mainly pattern is this nest and lobule. At few places they are making the cords like structures, like here there are cords like cord like structures. So they are making cords, and at places they are solid, they are also in solid sheets, like here they are making solid sheets. So this is less differentiation is there. Here they are also making this solid sheet. So solid sheet is there. So this is toward more less, this is more toward poorly differentiating or moderately differentiating. Here we can appreciate these tumor cells in sheet. So this is less differentiating, or we can tell this is moderately differentiating. So mostly in nests, lobules, and in sheets. Few keratin pearl formation is seen, along with individual cell keratinization and this intercellular bridging. We can appreciate intercellular bridging here nicely. So here we can see this intercellular bridging. Nice intercellular bridging is there. So we have done P16 immunostain for this case, and we will see that slide also. So this is the P16 immunostain. So this is the stratified, overlying stratified squamous epithelium, that is the mucosal layer, and this is the submucosal area. In this submucosal area we can see these tumor cells. Those cells have taken both the nuclear and the cytoplasmic staining for this P16 antibody. So this is called as block positivity for P16 stain. So this is beautiful P16 immunostain, block positivity. And for to call these as P16 positive squamous cell carcinoma, mostly which is associated with HPV, human papillomavirus infection. So there must be at least 70% of the cell should have this immunopositivity. So here that criteria is fulfilled. Mostly most of the tumor is positive for this P16 immunostain. So this is P16 positive or HPV associated squamous cell carcinoma. Here we can appreciate another feature which is more prominent in this immunostain, that is there is some amount of this peripheral palisading is present. So in case of this HPV associated or P16 positive squamous cell carcinoma, generally this basaloid pattern is present. Although basaloid pattern is little bit toward poorly differentiating, but here we can appreciate many nests are there, so at least moderately differentiation is there. Here there is this sheet-like arrangement, sheet-like pattern, so which is denoting toward more aggressive or toward moderate, minimum moderate. It can be poorly. If it doesn't have these proper nests and lobule, then we can call it as poorly differentiating or moderately differentiating, SCC. So again, if we go to this squamous cell carcinoma H&E section, so we can appreciate this overlying squamous, stratified squamous epithelium along with this submucosa or subepithelium is infiltrated by this tumor having arranged in nests, sheets having arranged nests, and then sheets of tumor cells having pleomorphic nucleus, having different size and shape of nucleus with atypical mitotic activity, and intercellular bridging is prominent along with few keratin pearl formation is present in an individual cell keratinization is also noted. So we can sign out this case as squamous cell carcinoma, oral cavity, HPV associated. Thank you.